we can, I'm going to get you rolling here, Maria. I wanted to welcome everybody who's attending our grand rounds today. I'm Dr. Joanne Talbot. I'm one of the emergency doctors at the St. John Regional Hospital. I'm the site academic head. It's really a pleasure to invite everybody to our rounds today and to hopefully invite you to present as well if there's something that you're very interested in the exciting field of emergency medicine. So today we're going to start off with a talk by Maria Kovalik about discharging the elderly. This is an area of interest for Maria, and she's working with our team on care in later life. So thank you, Maria.
Thanks, Joanne. Can everybody hear me? Hopefully. Okay. So I wanted to talk to you guys about discharging the elderly. It is starting to become a bit of an interest of mine, just basically geriatric care, and something that I feel kind of uncomfortable with still in our department, because you do take on so much risk when you are evaluating geriatric patients and then ultimately sending them home, and always wondering what kind of follow-up they really truly get and what are the chances they're going to come back and bounce back or get sicker. Okay, so I have no disclosures. So here are my objectives for today. I want to acknowledge the complexity of a geriatric patient. I want to identify the emergency department's role in treating the geriatric patients. I want to list the emergency care recommendations for geriatric care in the emergency department, and describe different care models that other sites have used and the studies that go along with those. And at the end, I was going to have somebody from extramural come and speak to us about the services available and how follow-up can work with extramural. Unfortunately, they canceled last evening kind of suddenly, and I'm hoping that I can work with them to maybe reschedule and make that a longer talk in the future. So my talk might be a little bit short today because of that. And if you guys have any questions, just go ahead and interrupt me during my presentation. I really don't mind that. So let's get started. So who are we, and where do we stand in the care of the geriatric patient? Well, we're kind of in that middle zone, kind of like in limbo. We have one foot out in the outpatient world, and we have one foot out into the inpatient world. And sometimes we're the portal between those two. Sure, there's ways to get from the outpatient to inpatient without emergency department access. But when those services break down, we truly are that portal that patients use to either get reconnected with outpatient services or have them connect us to inpatient services. And we do play a key role in the geriatric care in that regard. So it's no surprise to you guys that our population is aging drastically and quickly. And especially in the Maritimes, we have a large population of geriatric patients, and they're becoming more complex. Their comorbidities are becoming greater. They have bigger polypharmacies. Cognitive impairment plays a huge role in communication difficulties. Access to primary care is becoming more difficult with less family doctors available, especially in the St. John and New Brunswick area. And of course, there's socioeconomic consideration. Not a lot of people have the finances or the supports in place to make their lives easy, especially as they age and their children start to age as well. All that adds up to longer lengths of stay in the emergency department with multiple handovers from one physician to the other. And their likelihood of admission is increasing as well as their age increases. So here are some of the Canadian stats available. So over the age of 75, have a highest ED visit rate in the of any other segment of the population. A 2002 systematic review estimated that an average mortality rate of 10% in the 3 months following an emergency department visit in the elderly population. And an estimated of 24% of elders discharged from the emergency departments will repeat visit within 3 months. So I thought I'd kind of look at some of the stats that we have. And thanks to David, he gave me the last year's statistics for our emergency department here in St. John. And mind you, got to take it with a grain of salt. This is COVID time, so things are a little bit different. But this is our total ED visits. So 8% of those were between the age of 60 and 80. 8% of those were 80 and above, and 84% of the rest of the population. If you look at our bounce back, and then 72 hours, not even 3 months, but just 72 hours for the last year, 20% in the 60 to 80 age category. Over the age of 80, it's 6%, and all other ages, it was 8%. And our admission rate in the last year, you can see that between the ages of 60 and 80, it's about 27%. Over the age of 80, 38%, and all other ages was 16%. So I think we do trend along with Canada. I mean, the stats are not quite comparable, but I think we do trend similar to the rest of the population now. We're seeing a lot of older patients, a lot of them get admitted, and a lot of them bounce back. So since the early 2000s, geriatric emergency medicine has come to the forefront, and there have been attempts to make recommendations happen in regards to the kind of care we should be providing in the emergency department. The Canadian Journal of Emergency Medicine has come up with these recommendations. I find these are quite good. They're a little bit broad and open to interpretation, but I think they're a great start. So I'm just going to read them out loud. So the emergency department should recognize that older people are the core population of service users. Emergency department should identify that adequate care of older people often involves an interdisciplinary and multi-specialty approach. Address safety and accessibility issues for older people with the design of physical environment and available equipment. We should ensure that the needs and goals of older people are considered at all levels of decision-making. Emergency departments should establish policies and procedures that guide holistic, person-centered management of problems common to older people. Emergency departments should facilitate education about issues common to older people. We should actively support patient-centered care to optimize outcomes, and we should include strategies for safe and effective transitions of care. I think these kind of recommendations can be used for any vulnerable population, but I think they really do ring true for the geriatric patients that present to emerge. Oops. Sorry, there you go. So the American College of Emergency Physicians collaborated with several societies, including the American Geriatric Society in 2014, and they came up with much more specific recommendations, in fact, 40 of them in total, to address geriatric care in the emergency department a little bit better. And they really, I mean, their goal is partially to bring geriatric emergencies to a forefront and to make them much like a subspecialty care in emergency department as we see with trauma and pediatric emergencies, and make it its own thing with its own goals. So I've tried to summarize some of these recommendations in groups and highlight some of them. So I'll start with staffing. So the ACE specifically talks about that the staff should be versed and educated in geriatric care, and the staff should include physicians that are knowledgeable in it, nurses, occupational therapists, physical therapists, pharmacists, social services, specialists that are educated and specialized in geriatric care that can come to the emergency department and assess the patients. And if it's a very complicated case with a difficult social, social concerns as well as medical concerns, having a case manager present that can help manage this on a long-term basis. The ACE spends quite a long time discussing different kinds of policies and procedures that should be in place in the emergency department to make geriatric care more smooth. And one of them is to initially really identify your geriatric patients at risk. And that's with protocols that, that instigate screening tools that recognize early fall risk in the senior, that assess for delirium and do cognitive assessments as well. But they go further. They also talk about having procedures in place regarding pain management and fluid resuscitation and avoidance of pressure sores and wound care. The AC also spends some time talking about how we should be discharging our patients home in a more organized fashion. They talk about printing out our discharge summaries in a large, bold font that's easy for our geriatric patients to be reading. And those discharge protocols should include not just the diagnosis, but also if there were consulting services involved, their consulting notes, the results that we've done, and the investigations we've done, as well as detailed discharge instructions, what to look out for, when to come back. If there's medication changes, they should be on that discharge summary, as well as any new medications and a follow-up plan. Speaking of follow-up, they spend some time talking about appropriate follow-up for a geriatric patient. And that has to be concrete. So already follow up with the family doctor, not just in a week randomly, but to have actually a established follow-up in 48 hours, for example, or a little longer, but also follow up with case managers, social services, or in our case, maybe extramural, that can assess the home and assess the mobility and the safety of the home, as well as see if they're taking their medications appropriately as discussed in the emergency department. No, you don't. The ACE also speaks about establishing an education program in our emergency departments, talking on a regular basis about geriatric specific care. They also talk about having an equality improvement plan in place so we can assess if we're doing well with our geriatric patients or if we're having an area where we need to grow. And finally, they talk a lot about equipment and supplies that should be available in the emergency department. And that includes appropriate lighting. Instead of having stretchers, maybe having reclining chairs that the patients may be feeling more comfortable sitting in, walking aids that would be available in their homes. So not just a 4-point walker, but appropriate canes and so forth. And hearing aids and visual aids as well. So if you really want to summarize it, they really talk about having appropriate staff in place, having a multidisciplinary team, physical infrastructure that's going to help you with your geriatric patient in an efficient way, but also procedures and policies in place that's going to make everything go smoother. So again, since the 2000s, there's been many different care models that has studied and implemented, and they seem to really vary a lot. There's a meta-analysis and systematic review that's looked at a few of them. I've picked 3 ones. So there's an Australian model. It was quite detailed. So they had a comprehensive geriatric nurse assessment done. They had a home visit with a nurse in 24 hours after discharge. They had a really strong discharge plan. They had all the referrals already established and times when the patients were going to go see those before they left the department. They had a 4-week home-based intervention plan. They had weekly interdisciplinary team meetings regarding complex patients. And they tried to provide a seamless transfer of care into the community. A more simplified Canadian model was tested as well, where they tried to identify the seniors at risk using the identification of seniors at risk screening tool. Once those patients were identified, They had standardized geriatric nursing assessments to identify their fall risk and their cognitive impairment.
Not really emergency stuff, right?
This is emergency stuff. This is what they say should be in the emergency departments.
Oh,
Yeah.
And somebody might mute their mic, please. I can hear you in the back. So they had team discharge care planning, and they had community service referrals available in a timely fashion. And US models, there's many US models, this is just one of them. They identified high-risk patients using a different screening tool there. They had also geriatric nurse assessment, discharge planning, and then they had very specific community follow-ups arranged in 48 to 72 hours. So this systematic meta-analysis reviewed those 3 plus 10 other articles, and they looked for outcomes including bounce backs to the emergency department, unplanned admissions, mortality post-discharge. And their results were varied quite a bit because all these articles seem to be, well, they're not very homogeneous. And so a lot of them did not have a good arm of control. And unfortunately, they were unable to find any data that showed that none of this kind of works. So they didn't see any change in discharge times. They did not see any bounce back improvements, and they did not see any rates of admission. At the end, though, they did comment that the data was just too weak, and there was too much variabilities in all the studies to make any good conclusions from that, and just basically said that more studies need to be done that are of higher quality. This article, though, came out just this year, Emergency Department Interventions of Older Adults, a systematic review. And sorry, I just don't have my presenter's view in front of me. There it is. So they studied 17 articles looking at number of, not just the type of intervention, but number of interventions in each of the studies. And then they focused on the interventions and how they would affect functional status, quality of life, the patient experience, and also bounce backs to the emergency departments and unplanned hospitalizations. Again, the studies themselves were quite variable. Some of them had a control arm, which was just standard of care. Some of them were randomized. Obviously, none of them were blind because you can't really make this blind. And they found that there was some functional benefit in status. If you looked at all the studies, there was no overall effect in ED return visits. But if they looked at the 3 good quality studies that had more than 3 interventions in their arms, and if they extended and those studies also extended the length of time they followed the patients, they actually did see a benefit in that the ED return visits were less and the hospitalizations were less. So maybe a little bit of an improvement. So the more interventions you have in place may show that the better your outcomes might be. So there's the care models that are available. And in the States, some hospitals have gone to geriatric observational units. There's about 100 of them right now that are accredited in the States. Only 10 of them have reached like the highest standing of accreditation for geriatric assessment. And I could not find any data when it came to Canadian sites. So unless you guys know of any that have observational units, I don't know any. But here's how they do it. So in an observational unit, it's 6 to 8 beds that are allocated in the emergency department specific for this unit. And their expectation is that their length of stay is going to be probably anywhere from 8 to 24 hours. And it starts with a step 1. So step 1 is the emergency department nurse is going to assess the patient and do screening questionnaires with them to identify your high-risk patient for geriatric evaluation. The emergency physician is then alerted and does a chart review and a screening review and decides whether this patient just needs an admission, and they go through standard care that we usually do in the emergency department. If it's a minor issue that they think needs to be just discharged, they'll go through standard of care as well. But if they seem to be qualified for a more in-depth assessment, they will go to this observation unit. So once they're in the observation unit, it becomes a multidisciplinary approach. So a detailed geriatric assessment is done, and this is staffed by physical therapists to assess gait and fall risk, occupational therapists that can do mental status exams and possibly even MOCAs, pharmacists to review the medications and if there's any high-risk medications on the list, consulting services that can come down in a timely manner to assess the patient, like geriatricians, and hopefully come up with a care-based plan that can get this patient home in a safe way. So what can we implement in our emergency department? I mean, it'd be great to have an observational unit. I don't know if we have the funding, the nursing care available for that, but we can start a little bit smaller. We can start identifying our high-risk patients by starting to do some screening questions to identify the patients that will need a little bit more care. We can start creating a multidisciplinary approach, get a social service worker available to the emergency department, not just to call down, but to have a permanent one there that's going to be there at least for 8 hours. And that's not only going to be beneficial for our geriatric patients, but also vulnerable adults as well, such as addiction, homeless people who will also probably require social services. It would be great to get a physical therapist, an occupational therapist involved, and really start working on our discharge plan, maybe printing out those discharge summaries. And it's extremely important that we have, I think, a better connection with our outpatient services. It's difficult to get into a family doctor in a timely manner. 24 to 48 hours seems to be next to impossible in my experience, by maybe liaising with their family doctors and geriatricians to make that a priority. All right, do you have any questions? So basically there was supposed to be an extramural part, but unfortunately that's not gonna happen today.
Thanks, Maria. I'm sure people have maybe some questions about the extramural program, and maybe we can invite them in at some other time to talk about it. But just to start off, is there anybody who has some questions for Maria on the emergency department assessment of these patients?
So Maria, if you're going to do one thing, if you're going to change one thing, what would it be?
Couple. I think better follow-up. I think sometimes you discharge patients and it feels like you're discharging them into the ether. You tell them to follow up with their family doctor in 5 days and you know that's not going to happen. If you want them to have a geriatric assessment, as far as I understand, it takes months to get one as an outpatient. So we often admit patients from the emergency department just to expedite that geri assessment, which is not necessarily the best option considering that we're already so bed blocked most of the time. And if things can be done as an outpatient and it's safe within a timely fashion, I think we could really strive towards that. I think it will help a lot with the bed issue as well we're having.
Just a comment, Maria. I think a few years ago, and I can't remember how long ago, it might have been 10 years ago, we did have a full-time social worker in our department. And I can't tell you what a benefit that was in terms of sort of getting discharge planning going. They actually could activate the extramural hospital, OT, PT. It really was an enormous service, similar to the service we're getting from pharmacy. And I'm not sure why that fell off, but I think that would be a really good first step to kind of at least help us with discharge planning.
Yeah, and if we have, if we can identify those patients early, so if we have a screening questionnaire in place for the nurses to do, we can plan for the social service to get involved right away if we had one available to the emergency department. I know we have one on call technically, but I don't know how many people have tried. I've tried contacting the social service to come down. I think because they're not versed in the emergency department, they seem to have little to offer. So to have one available to us full time in the merge, I think I agree would be very helpful. And I heard really good things from a few years ago when you guys did have one. I don't know why that was stopped.
The argument at the time was that they've been hired to decrease inappropriate admissions and find appropriate home placements for them. It just never happened. And probably unwisely, they thought there could be cost savings by cutting that job.
Fair enough.
I think we should clarify. Thanks, Maria. That's excellent. It wasn't any decision within the Department of Emergency Medicine or the program. It was a Horizon decision to remove this, and there's been a standing request for this return ever since, as far as I'm aware, and it's been re-emphasized this year. I've even written to the health minister and spoken to the health minister about placing a social worker in the emergency department, and she's supportive of that. What I'm told is that right now there's no funding for it, but that they're looking into it, as always. So we will see. But it's on the radar, so it's not like it's been forgotten about. And I think it would make a difference, especially if they were available weekends, because one of the problems we have is, it's hard to get anything set up at the weekend, especially, and then it ends up to more admissions and blocking the beds in the hospital and our department. So, yeah.
And it's not just the elderly patients. I managed to get a social worker down last week for a lady that was coming back every 6 weeks to the department for life-threatening asthma exacerbations because she couldn't afford inhalers. And the social worker was able to, talk her through the right forms to get an assisted drug plan so she can now afford her inhalers. So I think there's more work in the department than we have. We could justify a social worker 7 days a week really easily in our department.
I totally agree. So, our vulnerable adults, our homeless population, our alcoholics, drug users could also benefit from a social worker to help them with housing and getting their medical benefits in place. That could be really helpful as well.
Have we ever had a meeting with the geriatric team, Maria, about our concerns with access to them and, what possible links we could get with them in the emergency department?
When is that?
Oh, no, have we ever had?
Oh, and I've not been part of one.
Maria, is there some basic equipment that you've identified that maybe we could get more quickly to help augment the care?
So Jerry chairs reduce falls
Mm-hmm.
In the emergency department, and reclining chairs. I actually saw one yesterday in the department, but they're rare to see. They reduce falls and they reduce agitation. So it'd be great to get a few of those. Hearing aids or visual aids, even a few glasses of different strengths that we can use that reduces delirium and agitation in patients as well.